Well, welcome to the surgical grand rounds. We've got a few of us in the room here, and we have a number of people online, including, I know, the seminar room over in the Churchill, the urology seminar room with a bunch of folks there. So it's a real pleasure to have you here. Real treat. A trio of experts joining us from the preoperative assessment team. Those of us who are surgeons or support teams, scientists, support teams involved with surgical care and benefiting from surgical care will recognise that we're tremendously indebted to experts like these three and the teams they support for assessing, optimising our patients before they get to the operating theatre. I'm sure we'd all recognise that our patients are whole people, not just surgical problems. And the work that these guys do is invaluable, I think, in enabling that. So a huge thank you to you guys for coming to speak to us. I gather it's 9 years, you were saying, since you last did so. So it's been a long awaited. A few quick introductions to, I think, in the order that you're going to be speaking. So James Day is going to be speaking first. James leads the OUH preoperative service and has been so since 2020. Trained in Oxford in anaesthetic and intensive care. And then did some fellowships in intensive care medicine, I think, here and in Melbourne, in Australia. Is that right? I think Dave Hallsworth is then going next. David trained in anaesthesia in Oxford and has been a consultant here since 2015 after a fellowship in perioperative medicine and exercise testing. We won't mention your other activities that you what are the Pussycat Girls? He was previously lead for the preoperative service until 2020, I think, before James. And his clinical practice includes anaesthesia for endocrine surgery, HPB, and transplant. After that, Nik Sabharwal is a consultant cardiologist specialising in imaging and general cardiology for the last 10 years, trained in Oxford and London, former president of the British Nuclear Cardiology Society, and contributed to multimodality imaging meetings. So thank you to the three of you for joining us, and over to you, James. Thank you.
Thank you very much, Alistair, for that kind introduction. There'll be three sort of presentations joined together, and my role here is really to set the scene. So this is, if you put the NDS Oxford in, this is the picture you get out. Clearly surgery in Oxford is a very historic affair. I think that's well defined, that you have a nice logo, you have a Twitter feed, and you've got a lot of organisation behind you. We don't necessarily have that. Pre-op assessment is clearly in some form very important around surgical services, but has always been really embedded within surgical services. Then in the 2000s, there was a bit of a paradigm shift, mainly in terms of workforce, about who would do this aspect of perioperative or surgical care, and it's transitioned really in my clinical time frame. And David and I were saying before, you know, we both did this job as house officers, and I think most of the senior surgeons will remember that. I think most of us will agree we had no idea what we were doing, what the expectations were, with very little feedback unless it went wrong. So there's been this change in the late 2000s, really looking at dedicated POA nursing staff to deliver this, and it's probably very different for different surgical specialties, and somewhat the medical model has been a little late to catch up. So within our own trust, this is a picture of a couple of individuals. For those in the audience here, does anyone know who the one on the left is? There's only really one person that works in the OUH with glasses like that and a flagrant disregard for personal space. That is John Griffiths, who in the late 2000s set up and was asked by one of the professors of surgery to set up POA in the OUH. And actually, John spoke here almost 9 years to the day, 6th of December 2013. I put this up because actually it's on the wall in the Churchill. It's in the book about COVID. It's actually on John's mantelpiece at home. And I think what this says is humanity, and is that personal connection. And John was really instrumental in setting up the service here. And John has many things. I wouldn't necessarily buy a car from John, but he's a visionary. And he heavily invested himself in developing POA and also the people working in POA. And I think what was really key was he was able to very well share his vision with other people around him and motivate his colleagues to deliver a service. And I think tantamount to this sort of level of charisma is that over 90% of the people that he recruited are still working in the POA department. That includes me. He was pretty much one of the only consultants when I was in ST3s to suggest that I should think about coming to work in Oxford. And I know that he also recruited and developed David, Catherine, and a number of other consultants. He was instrumental about getting on board a lot of the processes we use here in Oxford, such as exercise testing, and in-house echocardiography used by the ICU team and working with the other specialties. So in essence, John had actually really built a team, and anyone involved in management, to build a team that is long lasting is one of the most difficult things to do. John still was heavily invested in the department, and so he emailed his slides from his talk last night. And I included this, and actually, clearly it was the time when Nelson Mandela died. And despite his vision, John did have to step back from the position after about 7 years because the workload and the implementation of it was even too much for his level of energy. So the role passed over to my colleague David Hallsworth, and he'll be speaking shortly. And I think it's key to. So David and John are quite different, and David was really keen starting to crystallise some of the processes we use in the department that has allowed the department to continue and grow as it has done over the last sort of 12, 13 years. And actually a lot of the pathways and processes we use were designed and conceived by David pretty much entirely on his own. At that time, there is no roadmap for POA or recipe book to go to. I took over in 2020, thinking it would be a little bit like this. However, I won't mention the C word. Something happened in March 2020, and it kind of ended up a little bit like this. So this is an organogram of POA in the OUH. So if we start at the top left, and we'll start to work our way down. The point of this slide is to show that it is a entity that has evolved with evolutionary pressures applied to it. And when that happens, you tend to get on the right, which is a bird of paradise, and you end up with this weird construct of lots of little services in different parts of the hospital. And I put this up to show actually it is really complicated. So just because you can label something as POA doesn't mean it's simple to conceive that the whole system is terribly complex because it's just evolved over the last sort of 20, 30 years. And it feels a little bit like one of these Heath Robinson inventions. However, pretty much all of the surgical pathways do flow through this common choke point, which is POA. So it does allow us to actually have quite an effect on a perioperative pathway if we can work out how to make change. POA is different to different people depending on your point of view. So for the finance guys, there's apparently 23 areas. I have no idea how that has been constructed. If you look at SLAM data, so anyone in management will know what that is. In terms of specialism, we can probably say there's 13 different areas. If we look at real estate, there's actually 5 areas across the hospital. So any solution to POA is going to be an Oxford solution to POA. That's not an arrogant statement. It's just that it's so defined by the structure of the hospital and all of these different influences on it. There's nurses involved across 4 divisions. They all tend to work in individual teams, and they're quite isolated from each other. Doctors work across it, usually under the banner of anaesthetics. They tend to work individually. There's not really a big governance framework to bring it all together. This has been a lot of the work over the last 2, 3, 4 years with myself and my colleague, Dr. Haji Padlow, to try and start to steer all of this. A big speed bump we had was COVID in the middle of this. When we actually look at the OUH as a whole, this is data from 2019. The surgical pathway is a beast. We do 51,000 cases a year. I think it's actually gone up in the last couple of years. We do elective 31,000, of which 17 are admitted patients rather than day surgery patients. And actually, I think in the last year we did 35,000 elective cases. So it is a monster to deal with. All of those groups on the right have some say about POA services. Royal College, then GIRFT, then this new thing called the Centre for Perioperative Care, and now actually the Care Quality Commission are going to even start to get involved in perioperative workload. I am assured that they are all necessary and they all do work together. I have actually spoken to people in these different areas, and they do say that they actually do speak to each other. However, it is a little difficult not to think about Monty Python and the Judean People's Front and the People's Front of Judea. Framing it in terms of what's going on out and about, this is a slide that's been used many, many times, and I think is actually a little bit misrepresented when I was at a meeting yesterday from the NHS Director of Elective Care. But the workload is going up. The numbers, the waiting lists, essentially add pressure to the system that we're doing. That's on the background that we have an aging population. Expectations about what we can and can't do to patients are going up. You continually push the boundaries of what is possible in surgery, and anaesthesia and perioperative medicine always has to chase that. I think the problem, the aging population, is not only increase of comorbidity, but it's the variance. So 20-year-olds, 30-year-olds are pretty homogenous medically, but when you get older, you get a lot of divergence, and that's what kills pathways, is not the numbers, not even the risk or decision making, it's the variance around it that makes it really difficult to run pathways. How have we responded in Oxford? So this is looking at the sort of central POA group, and this is looking at the numbers coming through POA. So you can see that sort of 2021, there was a bit of a drop off. That's due to COVID. I'll just leave this slide because that's quite important to frame what's been going on. So that's an increase of productivity by 50%, with no increase in resource. So the POA department is working really hard, and that has been directed centrally, having looked at the way some of these disparate groups are working, was trying to increase efficiency and starting to actually ask the department to look at their processes and try and improve that. And there's been a lot of work in the background with many, many people involved to get to this point. Can't really make a talk nowadays without including digital. Everyone is going digital. We've embraced that. And these documents that we use and processes were all really conceived as part of a 2-year project that was which started 5 years ago with David Hallsworth. COVID was a real speed bump in that, but it does feel a little bit like one of those kind of fractal drawings where you look deeper and deeper and it just keeps going round and round. So any digital transformation, I think, takes much longer than people imagine. So essentially, before we get on to the other talks, what is POA all about? Well, an important thing is it's not a service model, it's an insurance model. We're there to think about risk and actually try and define it and try and reduce the risk. Because once someone has done something heroic and exciting, everyone wants a nice, safe place to land. And talking about that variance again, it's not the black and white stuff. That's really easy and pretty obvious. But unfortunately, we're dealing in shades of grey here. And a lot of our patients, we're a regional service for a lot of specialties. It's all dealing in the shades of grey. And that's where the problem lies. The way we used to manage it was this kind of end of a bedogram, paternalistic kind of decision. It's psychologically alluring. It's very appealing to think that's how medicine works. So just, house at the end of a bed, everyone's standing around looking, and that's how we did things many, many years ago, but there has to be an evolution around it. And essentially what we're talking about really is a professionalization of this POA service, which really is still very much in its infancy. It's only really been going for about the last 10, 15 years. And in essence, POA is about making decisions. And we will talk about the process around it, but a lot of people get hung up on the actual process, but it really boils down to making one or two decisions. And we've got to make good decisions because actually the risks are high. And trying to work out actually what a good decision is, well, it's got to be patient focused, tailored to the environment we work, timely, reproducible, and it's got to stand up to external scrutiny. So there's an awful lot of people involved in making these decisions. Hopefully it's not like this. I use that really just to show there's lots of different people involved. Hopefully it's getting on for a bit more like this. But these are some of the people, you know, surgical team is key, all of that involved, and all these other people on the right-hand side are involved into making good decisions. Now, the problem is that no one person is going to be able to make a good decision. It's a team that's making a good decision. And the problem is that we're all specialists in our own area. And so sometimes conversations, discussions about patients gets lost in translation. This is an elephant that's been examined by blind monks, and I try and squeeze it into every talk. The point is that depending on your point of view, you'll have an entirely different opinion or impression of what you're trying to examine, which is in this case an elephant. I'm not trying to say that patients are elephants here, but I'm trying to make a sort of a metaphor there. And this pops up on my Twitter feed quite often, and hopefully we're trying to transition to that right-hand side. So this is a good film if anyone has seen it, and it looks at essentially producing an aggregate team. So rather than having single specialized marquee players in a baseball team that win the team or win the games, it's essentially putting together an expert team. And this is what we've been trying to do over the last few years as part of the process of developing POA. It's not just us here in Oxford, the Royal Colleges advocate it, and as part of the guidance and accreditation departments, there should start to be MDT working. However, there is no definition about how we do that. It's really up to us to work out how to do that. So I'm going to hear a little bit of an example of some really expert teamwork in a couple of cases that are going to be presented by my two colleagues. There's very little evidence about it. Not sure you can ever show patient outcomes. A lot of this is operational. It's making good decisions and making them in a timely way that's sufficient for the trust in the patients. The results of the one paper on MDT working coming out of Canada did show that these outcomes. There's another reason to do it. This is a quote from a colleague that I won't name. It's actually really good fun. And I think this is why a lot of us went into medicine, is to work with high quality colleagues and individuals to deliver really good care. I am going to pass over to my colleague, David Hallsworth.
Thank you, James, and thank you for inviting us to be here. Like James says, it's been a long time and there's been an evolution in preoperative assessment. I like what he said about the professionalisation of pre-op, because I remember as a house officer to the night before surgery, I'd be on the ward with no idea what I was doing, just kind of bluff it to make sure that nobody noticed that the blood results were a bit off and hoping to be okay. And then I've gone through a time of working where I worked with some anaesthetic consultants initially who were sort of there on a sessional basis, signing off some ECGs and a bit of knowledge in what they did, to coming to myself, who I believe first consultant anaesthetist in Oxford with perioperative medicine in my job title, and now coming through lots of other people who have a professional interest in this. This is a big part of my job plan. And like James says, it's something I'm really interested in, so it's great to be able to come here and talk to people about the sort of work that we're doing. I want to bring it towards something a bit more clinical and to talk about a patient who went through this process. And with the sort of numbers that James is talking about, I kind of think about pre-op almost like the car industry of Hyundais and Bugattis. You know, the Hyundais, great cars, but you know, they're cranked out through the system. They're cranked out in their tens of thousands and quality controlled at the end, and they're your ASA1 hernia patients. And then there's the Bugattis that are hand built with care and attention. There's very few of them, and this patient is kind of like a Bugatti, but he's kind of like a Bugatti where you look under the bonnet and things are a bit rusty and not working well. So this was a man who was 74 years old. He presented to Swindon with obstructive jaundice, and long story short, was diagnosed with cancer in the head of his pancreas. Nasty tumour, quite big, compressing the SMA and the celiac axis. So a borderline operable case. And he'd actually been very well his entire life. He'd been running half marathons up until his 50s. He'd had a tissue aortic valve replacement 5 months previously at Brompton. And when you asked him, he said, yeah, I'm great. I can, you know, easily walk 2 miles. That's fine, not a problem. But when he turned up at my clinic, he clearly wasn't quite as good. When I walked him the 200 meters to the exercise testing room, he got a bit short of breath. And some of that may have been his new diagnosis of atrial fibrillation that found on an ECG that morning. He had an absolute iron deficiency anemia. And when you examined him, he had some bipedal edema as well. So he's clearly got several problems: cardio, respiratory, hematological, oncological. And we've got to make the decision, is this man fit for surgery? Or do we need to pause and make things better? Or is he indeed not fit because he's such a borderline physiological case, such a borderline tumour? So one of the ways we can look at this fitness is to put him on an exercise bike. And this is John. There's a video on YouTube showing how we do exercise testing in Oxford. What exercise testing does very well is it looks at how a patient can move oxygen from the air to the mitochondria. And what we're trying to do on an exercise test is stress the mitochondria by getting them to turn their legs against resistance, increase their oxygen demand. But you can easily substitute mitochondria for anastomosis or sutuline or skin or renal medulla, cardiac myocytes. So you didn't miss much if you didn't see the slides, just the preamble. So yeah, so looking at how a patient can move oxygen from the air to wherever that's needed. And in order to do that, there's interconnected systems of airway and lungs, heart, tissues, with the pulmonary circulation and systemic circulation in between them. And if one of these cogs starts breaking down or is sticky, the whole system starts to break down. There can be a little bit of compensation, but essentially what we're looking for in CPET is if a patient can't move oxygen from here to here, what's stopping them doing it? So the way we do that is by putting them on that bike. We have a mask on which measures the amount of oxygen they breathe in and out, and carbon dioxide that breathes in and out. This is a normal patient, or shall I say, incredibly fit consultant anaesthetist. We won't say who. So we put We put them on an exercise bike, and then around this point, this is time on the axis at the bottom, we start them turning their legs against no resistance at all, and we look at their oxygen consumption in red and their carbon dioxide production in blue here. So that does increase a little bit against no work. Then this line here, the ramped workload. So by putting resistance on the pedals, we make them overcome that in a linear fashion. And what you should see is their oxygen consumption increasing proportionally with the amount of work that they're being asked to do. Their carbon dioxide will increase proportionally with the oxygen as well in the aerobic state, but they'll get to a point somewhere where they can't deliver enough oxygen to keep those mitochondria respiring aerobically. And so the mitochondria shift to a different metabolic pathway, start putting out CO2, lactic acid, potassium, but their oxygen consumption still keeps going up linearly. So that's normal. You get a lot of data that comes out from a CPET. You don't need to worry about all of these numbers. I'm just going to point a few out. So this is him. What we can see is that he exercised to 77% of what we would expect him to do, which is not too bad. However, he only managed to shift around 13.8 milliliters per kilogram per minute of oxygen, which is 52% of what we'd expect. So there's a bit of a disparity there. He's working really hard and he wants to overcome the test, but his body can't do it. And we can look at the point where the system really starts to break down and he can't supply enough oxygen, the anaerobic threshold. Now that's only 9.1. Now, not too bad compared to a lot of the patients that we see. But as we will go on to show in terms of most general surgery, particularly abdominal and particularly the Whipple's procedure, that number is actually good. Now, the difficulty with some of these is that a peak oxygen consumption can be volitional. The patient can just stop because they don't want to do any more. They get a bit tired. CPETs are uncomfortable, but clearly he didn't because he got to this 52% point, carried on. And this number here, the anaerobic threshold, is subjective. All of these numbers are computer generated, apart from the anaerobic threshold, which takes an anaesthetist, whoever, to look at the graphs and eyeball it on. And James may get a slightly different number to me. What you can't fake is some of these graphs. Now, this is the same graph that we saw before, and you can see this linear workload being applied. But what happened with the normal subjects is his oxygen consumption went up linearly with the amount of workload that you gave him, but with this patient, it's fallen down. And right from a very low workload, he can't keep up with the demands of his mitochondria. So the question is, everything looks okay in the kind of raw numbers, bit deconditioned maybe, but if you make this man septic, if you give him some blood loss, you know, he's onto a loser from the very start. So something in that chain isn't working. And we can start to break that down into different systems. This is another one of the plots. So you see the orange line is his pulse, which is going up, achieving a particularly high number, although he was mildly beta blocked. And this here maps effectively his stroke volume. It's the amount of oxygen he pushes out per beat. But you can see that's a bit reduced. So there is scope to make this better if you can find out what the problem is. So the question is he fit for surgery? Well, okay, yeah, you could probably do a Whipple's on him. You'll probably get through the operation. The question that I like to ask is he fit for recovery? You know, is he going to get better from this? We can get anybody through any operation and dump them on ITU, but are they ever going to leave in a fit state? So particularly for Whipple's, when you look at anaerobic thresholds, there's been good work in Newcastle and Glasgow that have shown that ATs less than 10 are associated with a gamut of different complications, none of which you want. So in particular, increased hospital length of stay. Something that's really interesting is AT less than 10 predicts patients who are not going to get to their adjuvant therapy. And it's a sort of emerging concept of RIOT. So I call it return to intended oncological therapy, that the whole point of preoperative assessment and anesthesia and surgery is to get them through to their chemotherapy at the end, because that's one of the things that's going to make a long-term difference. So this guy has got some modifiable risks and he's got a nasty tumour. So he was given some neoadjuvant chemotherapy to downsize that tumour, which gave me a bit of time to play with him. So anticoagulated him for his AF because we don't want him to have a stroke in the meantime, but he could also have a clot sitting in the ventricle that we don't want to fire off during surgery. We can give them some iron and we can physically prehab them. We've got a very good iron deficiency management service, which I don't know if people know too much about. I set that up with Sue Pavel when I was clinical lead, and effectively you can get in touch with them via EPR. Patients who are iron deficient, they have a response time from referral to clinic, usually in terms of days, and it's fire and forget. So they will take that patient, they will give them oral IV iron as they need, they will follow them up, they will bring them back, they will give them extra doses. It's a fantastic service. This guy was given 2 doses of Ferinject over 2 weeks, and his hemoglobin went from 87 to 111 by the time of surgery. Now, it's a little bit controversial whether just treating anemia improves outcome in surgery. I think with this patient, where we've shown that he's got deficiencies in oxygen transport, it's difficult to argue not. And I think one of the problems with the studies like PREVENT is that patients didn't have much time. We're very time pressured with our cancers, whereas this guy's got a period of months. So giving iron 10 days before is not really going to change whether he needs transfusion for things like that, but giving it 2 months before probably will. We started physically prehabilitating them. So we have a prehabilitation team at the Churchill now that we set up to work in conjunction with Preop, but it's some real expert physiotherapists that, again, if you ask them to prehab this patient, they will. They will take them through physical exercises. They will take them through inspiratory muscle training. And with this patient, I found pre-op was a real teachable moment. So I said to him, these graphs, this isn't that great. This is good, but this is what you can do on a bike. Now, go and buy an exercise bike, sort of £100 from Argos. I give them a leaflet of how to use it with high intensity interval training. I've had some absolutely fantastic results with patients who've really taken this on, who've kind of taken that moment where they've just been on an exercise bike, seen that they can, and they've gone home and done. So 3 months later, he's had his neoadjuvant chemotherapy. We've boosted up his hemoglobin, but unfortunately, he's telling me he can do more exercise, but he's more short of breath. So I put him back on the bike. What we can see is this is the amount of work that he could do. So we've got 115 watts before, he can now do 150. That's great. His anaerobic threshold has gone from 9.1 to 13.7 with prehab and iron. Brilliant. His peak oxygen consumption, 13.8, 18.6. Great. But this is his respiratory rate at peak. So he's gone from a respiratory rate of 30 to a respiratory rate of 41. Going back to the graph that we basically looks at stroke volume, we can see that overall things have got a bit better. He starts developing this really weird curve. So if you imagine this is what his stroke volume, what his heart is doing, as he does more exercise, it pumps more and more and more and more. Whereas now he does more exercise, gets to a really good level, and then something happens and it all falls to bits. Same as before, we'd expect him to be proportional to that line, and he is, until a heart rate of about 100, and then it all starts dropping off. So this is where I start to really plug into this system and phone friends, because I need some real specialists to work out what's going on. So I got Dave Gary, who I think everyone will know, intensivist here, to do an echo on him. We've James and Graham Barker and Nick have set up this fantastic service where we have pre-op assessment echoes several days a week. We do it in-house. I think we're still the only unit in the country that does that. And the best thing about having an echo done by someone like Dave or James in clinic, as opposed to somebody who's obviously technically excellent at their job doing it in the basement of the heart centre, I can talk to them. And they know what this patient's going to go through in operation. They know what I want to know. We need to have that two-way conversation. It's what if and what can we do? Now, this guy, we know he's got an aortic valve. He's got a little bit of stenosis across that, but he's developed severe mitral regurg, which has caused some mild pulmonary hypertension, which is having an impact on his right ventricle and has impaired his systolic function. So clearly what's happening, this guy is looking better. We can put him under stress. He does well. But when we put him under a lot of stress, like an anastomotic breakdown, a collection, sepsis, everything's backing up through the system. His pulmonary pressures are increasing. His right heart is failing. So we need to take that to the team. James discussed a little bit about our high-risk anaesthetic meeting. It's done via Teams at 11 o'clock. On Friday, we have a range of people there. We have some people from pre-op, and these are all the people that talked about this guy. So pre-op anaesthetics, ITU, cardiology, renal. It's great when we're talking about these patients to have the surgeons there as well. If you can log in by Teams, if it's your patient. And the advice that came from Nick, looking at his echoes, we can all see them on the screen, is that this guy's overloaded. He had spironolactone at home. He was diuresed. 3 weeks later, came back. His RV's improved. His pulmonary pressures improved. His TR's improved. But what this high-risk meeting has done, as well as getting everything done rapidly, as well as being able to internally follow up, as well as learning for us, I think it's indemnified as well. So surgeons have had MDT meetings for years and years and years, where a group of people who know about it have got together and said this is the right thing to do. But anaesthetists have never really had that. So the person anaesthetizing this patient, because of the way our system works, had never met him before. So obviously I spoke to her beforehand, but she turned up on the day of surgery and saw all of this stuff without an MDT. She could be overwhelmed, and she may well say, wait a minute, I'm not sure, maybe we should back off, think a bit more. Whereas we've now indemnified that anaesthetist by saying, all of these people have looked at it, we've done all the right things, and they're okay to continue. And obviously it's very difficult to show improvement in patient outcome from this thing, because these patients are so bespokely managed and you can't study it. But I'm willing to bet a lot of money that our high-risk meetings reduce cancellations on the day of surgery and improve surgical throughput. So the outcome for this patient in the end, just because his surgeon sent an email to cpet@ouh.nhs.uk where he triaged it, he had his AF diagnosed and managed, he had his hemoglobin and iron deficiency treated, he had his functional reserve increased above what we would regard as the high-risk thresholds, he had his heart sorted out, he had surgery with a good outcome, he just had a chyle leak which settled with a low-fat diet. This was about a year ago. He's doing great. He's had his chemotherapy, and he's not quite back to running half marathons, but he's walking 2 miles, feeling really good, cancer-free. Thank you.
I'm talking a bit about peri-op cardiology, but being a bit of a forward as a cardiologist. I was introduced into this subspecialty, if you want to call it, by the great Oliver Ormerod, who I'm sure a lot of you remember very, very fondly. And if I could dedicate this meeting to him, I would. There we go. Right, so I'm going to quickly talk about some of the cardiac pre-op assessments, some of the cardiac issues. I'll zip through these and I'll show you lots and lots of pretty pictures, because I know surgeons like those over lots of hard data. The concerns when it comes to cardiology is cardiac function is your physiological reserve. That's the thing that gets patients through through the whole pre-assessment, and into surgery, through the F1 looking after the patient on the ward. We're clicking on valve obstruction. That's very important. Myocardial ischemia has a bit of an issue in terms of hemodynamics, and of course myocardial infarction. The image A in the top left is really important. If you have a poor exercise capacity, so 5 METs, and I'll define what that is in a moment. MET is a metabolic equivalent. At 10 years, half your patients are dead. And this is all comers. This isn't in a selected pre-op patient. This is just all comers. If you cannot exercise, if you're physically unfit, you have a reduced mortality. And that is incredibly important for your patients when you come to see them in clinic and say this patient requires surgery for their particular condition that you're specialising in. So a subject who cannot exercise is at much higher risk. Now, to give you an idea for what a metabolic equivalent is, sitting in this lecture theatre is 1, driving a car 1.5, carrying a light object, so we think that sort of, or walking up a flight of stairs around 4, swimming, that's front crawl, 50 metres, 9, 10. For those who are used to the old Bruce protocol on the treadmill test, stage 3 is 9 METs. That's the same level, by the way, that DVLA require for passing an HGV driving licence. So to give you an idea for what these metabolic equivalents mean, and I'll put the VO2s on the other side for reference. I'm also going to quickly give you a note about cardiac function. There's a lot of myth about echocardiography. Left ventricular function only correlates with mortality, not with symptoms. So I have plenty of patients with reduced ventricular function on an echocardiogram who have absolutely no symptoms whatsoever. The only reason that we like as cardiologists is it directly correlates with mortality. The right ventricle is very often ignored on the echocardiogram, but that is crucial for anaesthesia. So that's something we specifically look at the high-risk meeting. But all echocardiograms are load dependent, so your preload and afterload are incredibly important. They're very much affected by the heart rate and by atrial fibrillation. So there is an eyeball assessment that we quite often undertake. Please don't rely on LV ejection fraction. I will show you a case shortly with fantastic ejection fraction and terrible high-risk features. And the other thing that people get slightly worked up about is diastolic dysfunction. That's a sign of aging. I equate grade 1 diastolic dysfunction to cataracts, arthritis. That's absolutely normal finding. We really don't worry about grade 1 diastology. So I'm going to show one case. It's a 69-year-old female who's referred from another centre. She has hypertrophic cardiomyopathy with outflow tract obstruction, which is usually the thing that will turn most anaesthetists pale when you mention it to them. Just a bit of mitral valve regurgitation. This is treated in the usual way with beta blockers and disopyramide to improve to reduce the obstruction. Then she's found to be hypertensive, and a pheochromocytoma is identified. So this is a large, I've put a red arrow for those who are not interested in abdominal CT. There's a large pheochromocytoma on that abdominal CT. Now, so she was referred up. Obviously, we have a fantastic endocrine surgical service, which is very multidisciplinary. And so this immediately was flagged up to us in the high-risk anaesthetic meeting. As part of the patient's workup, she had a CT coronary angiogram. This is what a CT coronary angiogram looks like for those who are uninitiated. We get phenomenal pictures of the coronary arteries if we want them. And this is a service we run quite routinely now on the JR Churchland sites. And we get through about 30, 40 patients a week now. And this is the test of choice for instance through the chest pain clinic. For those who are interested in learning about it, find me. She's got normal coronaries. Her IVC is compressed. I will try and highlight that if I can. And she's got right renal compression. You look at that indent in her kidney. This is a big, big tumour. This is not a fun procedure. Now, for hypertrophic cardiomyopathy, we make them bradycardic. We like to increase the diastolic filling time to increase the stroke volume. Right, Starling's law. Remember the Starling curve? In order to increase your cardiac output, we push them slightly along the Starling curve by making them bradycardic. So they increase the heart, increasing them diastole, and that pushes the heart to increase the stroke volume. The thing we do not like is vasodilators. That makes things much, much worse. This patient was beta blocker, disopyramide. The next step is to put in a pacemaker. About 50% of patients will respond. So it's a bit like a random number generator. We don't know who's going to do that. We could have septal myomectomy. That's open heart surgery, or with alcohol, but alcohol takes 6 months to work and you're giving them a therapeutic infarct. Probably didn't have 6 months to wait. Or you stick in a mitral valve replacement. That could be metal, then she's anticoagulated with warfarin before you take out the pheochromocytoma. These are big, big decisions to be made in terms of optimize this patient. Now for the pheo, which is alpha blockade, which is a very potent vasodilator, and then you beta block them and then you operate on them. So it's the medical management of pheo is completely opposite to the medical management of a hypertrophic obstructive cardiomyopathy. So this is her echocardiogram when she came up. So we have in that big squeezy thing in the top is the left ventricle. The thing at the bottom is the left atrium, mitral valves in the middle, and we're seeing lots and lots of turbulence. The turbulence that's going into the sort of 8 o'clock, 7 o'clock position is the LV outflow tract, and the stuff going 5 o'clock is the mitral valve regurgitation. This is quite a lot of mitral valve regurgitation for that degree of LV outflow tract obstruction. Now, normal gradient across the LV outflow tract around 10 millimeters of mercury. Severe aortic stenosis, we worry at 65 millimeters of mercury. This lady was generating 200 millimeters of mercury across that LV outflow tract. It's incredibly high gradient. So, you know, we get interested at 4 meters per second. This lady was getting up to 8 meters per second in terms of velocity through her LV outflow tract, which should make you all go squeamish if you understand physiology. We did some tweaking around with her. I mucked around with her medications. This picture shows the LV outflow tract on the and the obstruction. If you look very carefully at the anterior mitral valve leaflet, it's bending back on itself through the Venturi effect, and that is causing dynamic outflow tract obstruction. And this is when we beta block the hell out of her with a heart rate of 52 beats a minute. So we tried very hard with medical therapy to optimize her. Did a few exercise tests, looked at the way the gradient changed, but basically with phenoxybenzamine alpha blockade, we just made her worse, and she got very, very breathless, and she's got severe mitral valve regurgitation. We came up with a plan. This involved quite a complicated set of MDT discussions, but effectively we decided we'd take it to theatre in the JR, cardiac theatres. Ryan aside, the head of cardiac surgery was there with Kate Grebenick. This was her last case, by the way. This is the great Kate Grebenick's last case at the JR. Team ready to put this patient onto cardiopulmonary bypass. Shad Khan, Dave Hallsworth, the whole endocrine surgery team were there. So it's a good example of multidisciplinary working, transesophageal echo in theatre, and we put together a whole different case of scenarios as to what we would do, plan A, plan B, plan C, plan D, and what would happen if there's bleeding, severe obstruction, blood loss. You know, we put together a very robust plan, and even then that had to change on the day, which I'll explain in a minute. But this is her intra-op TOE before knife to skin, and we have severe outflow tract obstruction. So this is the TOE, so the left atrium now is at the top and left ventricle at the bottom, and the mitral valves in the middle, and the aortic valves going off into the sort of 10 o'clock position. We've got severe mitral valve regurgitation, severe LV outflow tract obstruction with a heart rate of 40. So this lady actually admitted to the cardiology ward a week before, and we basically nailed her to the bed and increased the beta blockade up to a heart rate of 40 to try and improve the hemodynamics as much as possible. So we really tried very, very hard with this patient, and this took a lot of coordination. Right, she then ended up having her surgery, which had to be, the initial attempt at laparoscopic surgery was unsuccessful because it was so close to the IVC. So it was an open operation, which made it much faster, which was great from my point of view. But after the surgery, still with a still under anaesthesia, she has even worse mitral valve regurgitation with severe outflow tract obstruction. And this, of course, is a big problem when you come to extubated patients, when you've got this degree of outflow tract obstruction, this degree of mitral valve regurgitation, because they should go straight into pulmonary edema the moment you take out the tube and reduce all that positive pressure. So there was a few more discussions about this, and you can see her gradient is in the 150 millimeter mercury across the aortic valve. So she was ventilated over a cardiothoracic critical care unit, and this was her, and that was we had another meeting that morning and basically decided that as she walked into the hospital with severe MR and outflow tract obstruction, she would try and walk around rather than doing an emergency mitral valve replacement, because that was on the cards as to what to do with her. In the end, we extubated her 9 o'clock in the morning, and this is the echo very shortly afterwards. And she has severe mitral valve regurgitation, but she managed to tolerate it. And we managed to medically manage her for the next few days and did not require an emergency mitral valve replacement for her. 3 months later, having stopped all the alpha blocker, the mitral valve regurgitation is effectively abolished. At a gradient across the aortic valve is now 25 millimeters of mercury. So we had a 250, now down to 25. This is just from operating on a pheochromocytoma in a very multidisciplinary format and removing the alpha blockade. It was the alpha blockade, the vasodilator, which had clearly made it worse. And I've had a postcard from her. She's managed to do 7 days worth of 12-kilometer walks in the heat of Greece, 3 months post-op. So this was a fantastic outcome for this lady, and we haven't had to operate on a mitral valve, and I suspect long-term we won't need to do it. We'll get away with the medical therapy. So that's a great save. I'm going to quickly show you a few slides, but I'll be very quick on this. These are new ESC guidelines for non-cardiac surgery. They've just come out. I highly recommend them. They are very helpful indeed. For aortic stenosis, the big thing is symptoms. If they have no symptoms with preserved function, get on with it. It's a simple view. So don't worry, that's well established. If they have symptoms with reduced cardiac function, we'll probably want to intervene with a TAVI, but there's some issues with respect to timing and whether it's a low risk or high risk procedure. If it's a low risk procedure, we'll probably just say get on with it, especially if there's a time critical element to it as well. With mitral valve regurgitation, it's goal-directed medical therapy when they've got severe MR. And again, a lot of it's down to symptoms. If they don't have much in the way of symptoms, we'll usually just suggest at our meeting, get on with it with specific potential modifications to the outcome in terms of where they're looked after, whether it's coronary or IT or things like that. We have the capability locally now of transcatheter edge-to-edge repair for the mitral valve. This is a device that's put in percutaneously to reduce the mitral valve regurgitation, so we can do that if we need to. The new guidelines suggest that intermediate and high-risk surgery patients have a troponin measured day 1 and day 2 post-op. This, I think, is quite controversial. It's to look for a condition called PMI, or perioperative myocardial infarction. I'm not sure we want to be looking for it, but this is a suggestion. And they do stratify the different types of potential troponin release and what you might do about it. There is an algorithm here, which I would suggest you do look at. So if you have a patient with chest pain post-op and there's ST changes and they're anemic, they get a transfusion, should be considered for the cath lab. If they're not anemic, they go to the cath lab. Otherwise, they're suggesting an echocardiogram. I don't know how the resource is going to come, but we could talk about that. And then look for potential other causes of why they've got a troponin release, as sepsis, heart failure, PE, stroke, all those sorts of things. The treatments we've got are very simple. Aspirin, if you've got established coronary disease. Statins are very, very important in coronary disease. Beta blockers reduce ischemia, and they're very helpful in AF. Don't use clonidine anymore. The renin, aldosterone, renin angiotensin aldosterone system antagonist should be paused. And the SGLT2 inhibitors are the new statins in cardiology. We are putting lots and lots of people on SGLT2 inhibitors. Now this should be discontinued. Depends on the guideline. ESC, say 3 days. I think the trust say 1 day prior to surgery. I'll zip through coronary calcification. But basically, in clinic as surgeons, you should be watching out for hypertension and lipids, and they need treating. If they've got angina, it's a beta blocker. You can use one of these other drugs if you want to, and we try to avoid revascularization if we can, with dual antiplatelet makes trouble in terms of hemostasis. Post-op AF is very straightforward. Got symptoms, beta blockers, beta blockers, beta blockers. And if you're not sure, digoxin. And make sure they're anticoagulated. It really isn't that many more complicated. And if they're very unstable, they just need to be shocked out of it. Heart failure, there's now quad therapy for heart failure. Beta blockers, the angiotensin receptor neprilysin inhibitors, the ARNIs, that's called Entresto by its brand name. The mineralocorticoid receptor antagonists, so pleromone, spironolactone, and the SGLT2 inhibitors. New NICE guidelines say all diabetics with any form of cardiovascular disease should be on an SGLT2 inhibitor. So we are going to be using this on lots and lots of patients in cardiology outpatients. Watch this space. So you'll have to get used to these drugs, and especially the risks of diabetic ketoacidosis. We worry about PND orthopnea. If you see a patient in clinic and they've got PND or orthopnea, those are the only bits of the history you have to know about. PND or orthopnea, first year medical school, those are high-risk features. Don't worry about anything else. They've got that, they're in trouble. If they're hypoperfused, they're in trouble. If they decompensate, those are things that cause decompensation. You put them on non-steroidal, they'll decompensate. You give them a sedative, they'll decompensate. We're all about reducing the risk of surgery and their cardiovascular risk. And this is also an MDT approach. So we do this high-risk anaesthetic meeting, 11 o'clock on Teams. Join us. It's very educational. We even do ECGs for those who need it. Functional reserve, really important. Please assess that in clinic. Careful use of cardiac investigations. Notice I haven't said 24-hour tapes. You don't need to book them. You don't need to think about them. Targeted medical therapies, aspirin, statins, blood pressure, and plan in advance. Actually, the surgical contact, you are the ones who will make the biggest difference by sorting out the patient well in advance of pre-op assessment. Thank you.